Good morning. I'm so excited to be here, and thank you so much to Anne for the invitation. So welcome to all of you. I'm excited to talk to you about a topic that I've become more and more interested in as I've cared for more MPN patients. And really what I'm hoping this will be is more of a motivational speech for all of you to try to empower you to become more involved or to be more empowered to talk to your physician about what's important to you as an individual. So I have a few advisory roles that I need to share, none of which should be relevant to the talk today. And so I'm going to start with this figure. So I actually found this on an investor's website, believe it or not, and it really highlights the increasing investment that is occurring or has occurred and will continue to occur over the next decade in the development of drugs and treatments for MPNs. And these numbers here, this 11.5 is actually US billions of dollars. So knowing that this is all occurring, history would tell us that more investment leads to more available therapies. And as more drugs are going to become available to treat MPNs, I think this means that treatment choice may become more complex as these available strategies are there for you. So the positive side of this is that patients will have the ability to work with their physicians to develop an individualized approach to care. So Dr. Michaelis mentioned this concept of shared decision making. So I think more and more deciding on your MPN care will be more of a process of shared decision making. The National Institute of Health actually describes this concept as a collaborative process that involves a person and their healthcare professional working together to reach a joint decision about care. So in order to be a good collaborator at your visit with your physician, I do think it's important to have a little bit of background and understanding about how all that investment leads to drug development. So if you've ever participated in a clinical trial, you may realize that clinical trials are designed with a specific outcome of interest in mind. And those outcomes have to be predefined and approved by regulatory bodies before the first patient can even be enrolled in a study. So as was mentioned previously, MPNs are a very unique disease in that patients live a really long time. So outcomes like survival that may be more common in other cancers are very hard to measure. But instead, what we tend to do is focus our trials on developing therapies that reduce risk associated with disease. So in PV and ET, for example, a lot of our trials are focused on reducing that risk of thrombosis or what we call blood clotting events. And even that can be really hard to study in trials, so we often have to use a surrogate that we know does eventually lead to that reduction in risk. For example, really good blood count control, especially in PV, where you're trying to control the hematocrit. A lot of the trials that were approved in myelofibrosis actually were approved because they showed efficacy in symptom reduction, either by reducing spleen size, which was an impairment to quality of life for a lot of patients, but also reducing patient-reported symptoms. They also, now newer trials and newer drugs are being developed to improve blood counts, to free patients from transfusions, for example. And then it was previously mentioned too, one of the aspirational goals of research in the MPN space is to actually try to find therapies that have what's called a disease-modifying effect. So in my mind, this means what can we be doing to treat patients and reduce their long-term risk of progression to more serious hematologic illness in the future, and thereby improve their survival. So another nuance about clinical trials, especially in MPNs, is that not all trials are testing whether one drug is always going to be better at achieving an outcome than another. It's possible you're going to be comparing two drugs that may have the same outcome or may be equal or equivalent in having the same outcome, but one drug may be able to do that in a better way, whatever that means, right? So for example, perhaps one drug has fewer toxicities or side effects than the approved drug that's on the market. A thing that I am particularly interested in is, having talked to my patients, is that some of the new drugs are actually being developed to perhaps provide more convenience for the patients. So a drug that might be dosed once daily as opposed to 4 times daily, or outside the clinic instead of inside the clinic. So keep in mind that a lot of the MPN trials, or a lot of the drugs that are approved may be approved because of these types of outcomes. So I'm going to spend the next few slides then discussing this idea of individualized medicine and MPNs, both from kind of the clinical perspective or how we physicians look at it, but also how I think you should be looking at it as a patient. And then I'm going to try to provide you an example to kind of put this in a framework of how this type of shared decision-making discussion might occur in the clinic. And then finally have a couple of slides at the end that'll probably be more deeply discussed by the other presenters, but just kind of give you some hints of where I think the future of individualized medicine in this field is headed. So let's start with this figure. This is kind of how I broadly think of this concept of individualized or personalized medicine, as you may see it called. And I think there are just two broad components to this. So the first, which is really kind of how we physicians are trained to think about personalized or individualized medicine, is the biological component. So what do we know about your diagnosis historically? And then as more and more research comes about, how do we use information like genetics of your disease or the way your disease presents to really think about, you know, your risk of certain outcomes and how quickly things will progress. So this is a buzzword you might see on the internet or in talking to people that we hear a lot, maybe kind of refers to precision medicine here, particularly when it refers to like the genetic components of risk stratification. Equally important though, probably the most important thing that I want to get across with my talk this morning is the psychosocial component of individualized medicine. So this is the part that imparts your lifestyle, your goals, and your preferences for your care. Something we in the healthcare system like to call patient-centered care. And so I really feel like it's the combination of these two factors that lead to the perfect individualized treatment plan. So just to kind of take you through how this might come about in the clinic. So just to give you a little background, and I'm sure someone else will talk about this in more depth today. But when I see a patient with an MPN, one of the first things I do after confirming their diagnosis is to perform what's called a risk assessment. So for patients with ET and PV, really that risk assessment starts with understanding their risk of having a thrombosis or a blood clotting event, both in the immediate and far future. And we use different elements of the patient's past medical history as well as what we know about the genetics of the disease and their age to kind of come up with that risk assessment. In myelofibrosis, our risk assessments tend to revolve more about understanding the patient's risk of or likelihood of survival past a certain time point. So again, we take into account what we know about the disease genetics, as well as symptoms and signs of presentation. And many of you who have MF may have talked to your doctor about your score on the DIPS plus prognostic scale or MIPS plus or MIPS prognostic scale. So we have these sort of tools that we can use to sit down and talk to you at the beginning. But then we need to dig down a little bit into who you are and what you're experiencing. So once we've got this sort of generalized knowledge about your risk based on large pools of data with people kind of being put into one big pot and seeing what the outcomes are, then we need to talk to you and find out what is your experience right now and what do we need to address. So in particular, a lot of times when people present, they are having significant symptoms. Not everyone, but certainly people do. And so hearing about which symptoms are the most impactful to your quality of life right now is very helpful because we have certain treatments that we may think may be more beneficial for that particular symptom, right? So things like fatigue, itching, reduction in spleen size are all examples of this. Then we want to think about, of all the treatments we have that we could offer, what are the potential side effects and how will those play into your individualized care plan? So of course we have to think about your medical history. Do you have other comorbidities or medical issues that might make it more difficult to administer a treatment? But then I think also there are important things that my patients have taught me about the impacts of certain side effects on lifestyle, right? So depending on who you are and what you're trying to get accomplished on a day-to-day basis, there may be certain side effects that you just can't deal with. And so talking about these things is very important. A very, very easy example, which I'm not going to belabor, is obviously family planning. There are certain treatments. If you're a young person who's planning on a family soon, there are certain treatments that we probably want to avoid during that time frame of your life. And so again, being open about who you are and your immediate and long-term plans. So another very important concept that I think maybe gets a little bit overlooked, but literally my patients are the ones that taught me this, is that time required to get treatment is a really important thing to consider for people who are trying to work full-time jobs, have family responsibilities, have hobbies, just basically want to live their life and not spend all their time in the healthcare system, right? And so, you know, I've had patients that tell me that phlebotomy, for example, is quite a burden for them because they work at a very busy job all the way across town and don't have time to take off to come in and get their treatments. So anything like toxicity monitoring, transfusion support, all the aspects of your care take time and take time away from the life that you really want to lead. And then many of you, if you have heard me talk, you know I am a big advocate for being open to discuss the cost of treatment and what that's going to mean to you if you choose a certain strategy. It's not discussed enough, and there's actually research to show that physicians are very uncomfortable discussing it with their patients, and patients are very uncomfortable discussing it with physicians. And there's no reason for that because financial toxicity, not just the out-of-pocket cost to people, but also the stress and anxiety they have over getting things covered is a real impediment to optimal care and actually leads to not only poor quality of life, but can lead to poorer outcomes. So important to discuss. All right, so I'm going to start I apologize. I thought I had a little more time and realized that my talk is a little bit shorter. So I'm going to give you one example of how this might play out in the clinic to kind of share a patient story, much like my predecessor here. And then I'm sorry, I'm going to focus on one specific niche of a disease, but I hope that it will be an example of how no matter what your diagnosis, you can kind of use this sort of tool to interact with your physicians. So low-risk polycythemia vera is categorized if you are under age 60 and you've never had a thrombotic event before or a blood clotting event, then that puts you in this low-risk category. So for many years, we physicians always had what we considered this sort of cheap and easy treatment, which is to prescribe a regimen of therapeutic phlebotomy and with aspirin that's been shown to be fairly effective in patients with low-risk PV. In 2021, a drug called ropeg interferon, which you may have heard called Bezremi, was actually approved for treatment of low-risk PV. It was approved for high risk also, but what was particularly novel is this was like one of the first drug treatments that we had to consider in our low-risk PV patients. This was after the results of a study called the low PV study, in which patients were randomized to receive the ropeg interferon plus phlebotomy as needed versus just the phlebotomy and aspirin alone. And of course, everybody received aspirin. So what they showed in the study was that patients who received the drug were able to achieve a good hematocrit control over a 12-month time period and show no evidence of disease progression. And in this case, this meant progression of blood counts and lack of a blood clotting event. And a higher proportion of patients were actually able to achieve that than the patients just receiving phlebotomy. But they also showed signs that they were having increased iron stores in their body, which had some clinical symptomatic impact. Led to potentially improved symptoms of their MPN, but not fatigue, importantly, or fever, because those were actually more common in the ropeg interferon arm. And then there were a subset of patients, or a higher proportion of patients, I guess I should say, were able to achieve what's called a reduction in their JAK2 allele burden. So most patients with PV have this JAK2 mutation, and over time you could see a higher number of patients in the experimental arm like having a decline in that detectable level in their blood. There were, though, some increased side effects, as I mentioned, in the ropeg interferon arm. And this figure that I've got up here also highlights, in the pink, shows that over time there were fewer phlebotomies in the patients being treated with ropeg interferon 2. So I actually have a patient who is a scientist right at the beginning of her career. She has a family, so she's a very busy woman. And She, of course, does a lot of reading and is very knowledgeable at baseline. And she came to me because she was really, it's funny, the first time I met her, she had the most detailed outline of her disease. You know, she's very analytical, so gave me like all these details about her disease, but then had the most difficult time complying with her phlebotomy regimen, right? So I was like, what's going on here? This does not compute. But she actually finally shared with me what a burden this was for her to have to come across town to the clinic to be able to take time away from her lab and her job, and was really looking for something else. She'd also done a lot of reading about the results of the study and wanted to kind of talk it through. So, of course, you know, we talked about this sort of primary outcome of interest that the study was actually designed to measure, which was, you know, could patients treated with the interferon drug actually have more persistent count control than phlebotomy? And it did suggest that. And one could extrapolate that with better count control, that might increase risk of things like blood clotting events, although that was not directly measured or compared. It did reduce the need for phlebotomy, and that was something that was very important to my patient because this was just becoming too burdensome. She also had noticed that she was developing a lot of fatigue. She was like, maybe my job, I don't know, but she was showing signs of iron deficiency, and iron deficiency is kind of a necessary evil with phlebotomy. We kind of induce a little bit of that so that your body isn't able to kind of make those blood cells as effectively. And then, of course, being the scientist, she wanted to know what this means to have a reduction in your JAK2 allele burden or your JAK2 mutation levels, because she has young kids. She wants to live a long time and see them grow up and meet her grandkids someday. And so could this potentially lead to a reduced risk of progression in the future? So that's the last one. That last bullet point is the most difficult thing for me to talk about because patients are becoming very knowledgeable about it. But as was alluded to earlier, we don't have concrete data to say for sure that that's going to lead to a reduction in progression in the future. We like the idea of it. It makes intuitive sense. But really to be able to counsel my patients and make treatment decisions, I need to see that over the long term that does lead to an improvement. But we're waiting on that, and we're hoping to see data about that in the future. Finally, we had to talk about the risk, the other side of things, right? So there were more side effects in the ropeg interferon arm. What were those? How did they, how could they like interfere with her lifestyle? And finally, this person was a very highly functioning, higher socioeconomic status individual, but the cost was very important to her. So we actually made a plan to actually get a pre-authorization to truly find out how much it was going to cost out of pocket for her to go on this medicine. So I'm going to I have to skip over a few of my slides, but hopefully that shows you an example of how these types of interactions can occur. So just a couple of slides at the end here to talk about where I think the future of individualized medicine and MPNs is going. So many of you are probably poised or have heard a lot about new drugs that are actually developed to interfere with the iron metabolism pathway. So the most well-known of these right now is a drug called rusfertide, which is being studied and just had the largest phase 3 study to be completed, and is showing that there is an efficacy in reducing iron deficiency and the associated symptoms with that in polycythemia vera, but also is sort of aimed at providing patients with another sort of convenience opportunity where they're hopefully going to replace phlebotomy and allow patients to be able to give medication at home that has that same effect. We are also seeing an exciting new area of development for agents that target specific driver mutations. So historically, we've had JAK inhibitors, and that's what we give to pretty much everybody, even if you have a CALR and MPL mutation, and those have been effective in those patient populations. But right now, there are ongoing clinical trials looking at development of drugs that actually target the abnormal signaling pathway that comes about if you have a CALR mutation. So, keep an eye out for opportunities to participate in those trials if that is something that you harbor a CALR mutation for that. And then finally, Dr. Michaelis also mentioned this, but I one of the big areas of research we have is in looking at concurrent mutations that occur outside of those primary driver mutations. we know a lot of work's been done in myelofibrosis, so we actually have a lot of knowledge about how the discovery of these other acquired genetic mutations that we find in your bone marrow and your blood samples may impact prognosis. But we're actually starting to do a lot of work in ET and PV as well. And so how will that play out in the future? If we're able to identify certain genes that coexist with the JAK2 mutation or CALR mutation, for example, that carry with them an increased risk of progression or a faster risk of progression, perhaps those are the category of patients we should be talking to about earlier interventions with medical therapy as opposed to kind of the watch and wait approach as we'll do for some low risk patients right now. So really a revamping of this risk stratification I mentioned at the beginning. So this is just my summary. I hope, I think we all can all identify with the fact that the pace of drug development in MPNs is increasing, and it's an exciting time, a very exciting time. But I think individualized medicine is going to be more and more of a concept in MPNs, and it's going to be more nuanced as well. I think treatment decisions will be and should be guided by both the clinical evaluation as well as this collaborative decision-making process with your physician. And for you as a patient, I would say that to be a better collaborator in those discussions, take the time to really push your physician to help you understand if they're offering you a drug, what are the outcomes by which that drug was approved, what were some of the secondary outcomes, really kind of understanding how those trials were performed. And then please, please, every time you meet with your doctor, take just a moment to reflect on your own personal goals for your care, because I can tell you that will change. Your disease may change. Your treatment options are certainly going to change. I can certainly predict that. And we all know that over time our life's changed dramatically. So thank you for that.